A peripheral arterial disease diagnosis can be made on clinical history, clinical examination findings, and a non-invasive vascular laboratory tests. Both the history and clinical examination findings can be unreliable, and especially in patients with diabetes who often don't present with claudication and who have the most distal arterial disease, the examination findings and history can be unreliable. And that's why I think in any patient in whom you make a diagnosis of peripheral arterial disease, that really has to be backed up by non-invasive vascular lab tests. There are a number of bedside tests that are available. These include continuous wave Doppler, ABI or ABPI, which is ankle brachial index or ankle brachial pressure index, toe pressure, and then some microcirculatory tests such as transcutaneous oxygen measurements and skin perfusion pressure. Continuous wave Doppler is a very helpful method for confirming the presence or absence of PAD, but it does rely on someone being really quite experienced to be able to differentiate the sound between a triphasic waveform in a normal individual and a monophasic waveform in a patient with peripheral artery disease. But in those experienced hands, it is quite a reliable method for confirming or excluding the presence of PAD. But it really doesn't tell you anything about the perfusion in the foot. It just simply tells you or gives you an indication of whether there is atherosclerotic PAD. ABI or ankle brachial index is a very helpful method for confirming or excluding the presence of peripheral artery disease. And in fact, it's used in very large epidemiological studies to do just that. It does have its limitations, and especially in patients with calcified arteries at the ankle level. And of course, that's more common in patients with critical limb ischemia. And the problem with the ABI is that about 30% of people with critical limb ischemia have a normal ABI. And this is more common in patients with chronic kidney disease and diabetes. I think toe pressure is a very useful tool in the armamentarium to diagnose or exclude PAD. And it's especially helpful in patients who may have a spuriously high ABI due to arterial calcification at the ankle level, such as in patients with diabetes or chronic kidney disease. It also gives you an indication of the perfusion deficit and perhaps some information about whether the patient is at high risk of either amputation or failure to heal of a wound on a foot. TCPO2 or transcutaneous oxygen measurement and skin perfusion pressure are measures of the microcirculation. And they're quite useful actually in patients with diabetes and wounds because they give you some idea of whether a wound is likely to heal. So very low values, so typically less than 30 millimeters of mercury, would give an indication that a wound is unlikely to heal, whereas much higher values, such as greater than 40 or 50 millimeters of mercury of TCPO2 or skin perfusion pressure, would give you some indication or reassurance that a wound is likely to heal. And therefore that's quite helpful in the decision making, particularly in patients with diabetic foot ulceration.